Hi there, it's Dr. Suchard again with another clinical toxicology video for health science students. This time we're going to discuss opioid antagonists, corresponding to the Antidotes in Depth chapter A4 in Goldfrank's Toxicologic Emergencies. The learning objectives are that once you've watched this video and studied the related course materials, you should be able to name at least 3 opioid antagonists and identify which is the most important in treating acute opioid toxicity, and outline dosing regimens for that most important opioid antagonist. We're going to start off with this ultra-basic, oversimplified review of opioid pharmacology. In reality, it's more complicated, but this model is totally functional for our current purposes. Opioids will bind to opioid receptors, and the most important one here is the mu-opioid receptor, to produce their therapeutic or toxic effects depending on the dose. And if you give an opioid antagonist, you're going to reverse and block those effects mediated through the opioid receptor. Here we see that the opioid antagonists have a very similar chemical structure to morphine, helping to explain why they would be competitive antagonists since they will compete for the same binding site. On the top right, we see the structure of naloxone, which is the opioid antagonist we're going to be spending the most time discussing. But we can also see that naltrexone and nalmefene, which are longer-acting opioid antagonists, have very nearly identical structures too. Naloxone is the most important opioid antagonist for acute care purposes. It's available as a generic drug and also as brand name Narcan. That trade name explains its mechanism of action as a narcotic antagonist. It's available as an intranasal spray, which was made over the counter in 2023, and it's also used by injection, typically either intravenously, IV, or intramuscularly, IM, especially in cases where getting an IV might be time-consuming because timing is of the essence. The typical starting dose for naloxone is 0.4 milligrams IV. In most cases of opioid toxicity, 0.4 milligrams will reverse respiratory depression, which is the main goal in treating opioid toxicity. The dose can be repeated if there's no initial response. Some will recommend repeating naloxone up to a total of 2 milligrams, and others up to 10 milligrams. It's debatable whether some opioids may be relatively naloxone resistant and require doses that high, but there's little to no downside. However, at some point you'll have to stop trying more naloxone and move on to other interventions such as endotracheal intubation if the patient remains unresponsive and apneic. If the patient is known or suspected to be opioid dependent, there's concern that higher naloxone doses will precipitate acute withdrawal, which might complicate things for the clinicians and for the patient. So a lower starting dose of 0.04 milligrams naloxone should be considered, which can also be repeated and titrated to effect. For the most part in these videos, I'm assuming that we're evaluating and treating patients in the hospital. But since general awareness of opioid toxicity is growing, and naloxone is now available over the counter, I wanted to cover intranasal dosing too. The standard intranasal naloxone dose is 4 milligrams through an atomization device, which basically makes a fine spray which will be absorbed rapidly through the nasal mucosa. Dosing can be repeated every 2 to 3 minutes. If naloxone is given in the pre-hospital setting by a layperson, the hope is that paramedics will arrive before repeat dosing is required. The kits do at least come in 2-packs. And if the patient is already under medical care, hopefully we'll be able to get an IV by the time a repeat dose might be indicated. Naloxone and other opioid antagonists are remarkably safe in persons who are not opioid dependent, where they basically cause no observable effects. However, there is the potential in opioid-dependent patients to precipitate acute withdrawal, as already mentioned. And there may also be a risk for naloxone inducing acute respiratory distress syndrome when given to reverse opioid toxicity. However, opioid toxicity itself is also associated with ARDS, so it's not easy to know if naloxone independently also increases this risk. Naloxone has a pretty short half-life, around 30 to 80 minutes, and this half-life is shorter than that of many opioids. So there's the possibility, after reversing opioid toxicity with naloxone and waking the patient up, that they could later become resedated. Patients having received an opioid antagonist should undergo some period of observation until we think they're safe from this resedation. Now, heroin also has a pretty short half-life, so if we knew for certain that a given patient's overdose was from heroin, it might be sufficient to observe that patient for 2 hours after naloxone reversal. But what if the patient had opioid toxicity from a longer-acting agent like methadone, an extended-release preparation like OxyContin, or from some unknown opioid? Presumably, you should observe these patients longer for at least several half-lives of naloxone. The Goldfrank chapter recommends 4 or maybe even 6 hours. Should a patient become resedated, they should receive additional naloxone. And in some cases, this might be followed by starting a continuous infusion. For me, any patient who becomes resedated to the point I feel I have to give repeat naloxone after they've been awake and alert from the initial reversal is highly likely to be put on a Narcan drip. The recommended dosing for a Narcan drip is to give 2/3 of the total naloxone bolus dose or doses that resulted in initial adequate reversal per hour. This drip may be titrated as necessary, the patient will need to be admitted for observation, and the drip could be discontinued to observe the patient many hours or the next day later. So I've really only been talking about naloxone so far, yet there are other opioid antagonists, but they are generally not used for opioid overdose, which is what we're focusing on in a clinical toxicology course. Naltrexone and nalmefene are used primarily in the chronic treatment of opioid, and sometimes ethanol, dependence. Naloxone has a very short half-life, so it's not suited, say, for daily dosing, whereas naltrexone and nalmefene do have longer half-lives, so they are pharmacokinetically better suited for long-term therapeutic indications. And the longer half-life makes them potentially trickier to use for acute overdose if the patient is also opioid dependent. If you precipitated opioid withdrawal with a long-acting agent, that withdrawal could be protracted and much harder to manage compared to that occurring from naloxone, which is going to be gone within a couple of hours. That being said, in 2023, when this recording is being made, there is a nalmefene nasal spray available to treat acute opioid toxicity. Another place you'll see opioid antagonists used is for the treatment of opioid-induced constipation. Opioid analgesics are great for pain by binding to mu receptors in the nervous system, but they can also bind to mu receptors in the gut, slowing everything down. And here we see 3 of these opioid antagonists used basically as antidotes to treat constipation: methylnaltrexone, naldemidine, and naloxegol. The cartoon figure in the middle shows how constipation is part of the baggage that comes along with opioid use. Okay, that's it for the opioid antagonists. I'll be seeing you around.